Good evening, everyone. Welcome to another session of our monthly continuous medical education sessions by EMKF and facilitated by Daktari Online. My name is Kevin Nyacho. I'm a practicing emergency medicine specialist. And today we are going to be discussing about how to approach a patient who's acutely confused. Okay, so acute confusional state is something that is quite common if you work in an ED. It's synonymous with delirium, altered mental status, and there's a very old term where it used to be called transient psychotic syndrome. Some people used to call it acute brain syndrome. Okay, but for the purposes of this discussion and for all of you who are practicing or interested in emergency medicine, it's better off if you know it and term it as acute confusional state. Most of the time, when you put it as delirium, it almost always makes people start thinking about psychiatry because delirium is a whole topic in psychiatry under the DSM-5, and there are so many subtypes of delirium, which is actually not what we want. If you work in the ED and somebody comes acutely confused, uh, even if they do have a history of a psychiatric or psychological mental health disorder, that should be the last thing you think about after you've made sure there is no other organic cause of the acute confusional state. It usually is an acute disturbance of your brain function, normally for hours to days. Most of the time, most of the people who are brought in normally come in within 12 to 24 hours. It may be longer for some, for whatever reason. The clinical picture for these patients, sometimes they might be disoriented. They don't know the time, they don't know the place. They might not even be able to recognize the people who are known to them, the people who live with them or work with them. Their level of consciousness or alertness might be impaired, and they might even have memory issues. All this constitute the spectrum of acute confusional state. It doesn't really matter which one your patient has. It doesn't matter whether it's disorientation, spatial disorientation, or place disorientation, or even the loss of consciousness or impaired consciousness. Whatever it is part of the spectrum. They might have one or more of the symptoms of acute confusional state. Again, when we work in the ED as emergency practitioners, we need to be able to know that when you have these patients, the likelihood of an organic cause is normally quite high. More often than not, the causes of acute confusional state are organic. And if you don't, or if you're not able to figure out, it might contribute to prolonged hospital stay, poor treatment outcomes, and sometimes higher morbidities and mortalities. So at the back of your mind, when somebody comes acutely confused, please start thinking. This is normally, it's like a window for a lot of things, as we'll see in our discussion. Commonly, infections, which can cause acute confusional state. Infection of the meninges, the brain, that is meningitis, encephalitis, and its spectrum, meningoencephalitis and all that, can manifest as confusion. Tropical infections, malaria, again, can also present with acute confusional state. There is what we call cerebral malaria. It still does exist. UTI, pyelonephritis, spectrum, also does contribute, especially if your patient is elderly patients. Actually, confusion can be the only symptom of a UTI or pyelonephritis in the elderly. Community-acquired pneumonias, again, these are things to think about. These are very common things. There is a very nice tool that we normally use to determine whether you can treat your patient and release them to go home, or whether you need to admit them. And if you admit them, are you admitting them to a general medical ward, or are you admitting them to a critical care facility? The CAB 65, and one of the elements, the C actually stands for confusion. So confusion, urea, I think there's a value beyond which scores one, age, respiratory rate, and I think blood pressure. STIs, including HIV and AIDS, can also present in acute confusional states. These are all just examples of common infections that may, or one of the symptoms that your patient may come with is an acute confusional state. Okay, it doesn't mean that these are the only ones, but these are some of the ones you should be able to start thinking about. Other than infection, commonly endometabolic causes. Typically, electrolyte derangements. Sodium is normally the biggest culprit. When it's low, hyponatremia, your patient can present very acutely confused. Sometimes might even be having seizures. Sometimes they might even come in a coma or in an altered mental state where their level of consciousness is below the expected baseline. Sugar disorders, hypoglycemia, hyperglycemia spectrum, the DKAs, HHS, they can also present in an acute confusional state. So it's always a good idea when you're seeing this patient, one of the things you have to do quickly and at the bedside is a point of care testing for your blood sugar, which could actually be the only reason why the patient is confused. And then after that, you will need to investigate, have a full metabolic panel of tests, which typically includes electrolytes, kidney function test, thyroid function tests, vitamin deficiencies, especially thiamine, vitamin B1 is also a culprit of patients manifesting in acute confusional state. We can proceed to neurologic causes. All of the factors that are listed here essentially mean these are things that raise your intracranial pressure. Head trauma from whatever source, either blunt or penetrative. Tumors, convulsive or seizure disorders, hematomas, the subdural, epidural, subarachnoid hemorrhages. Remember when there's the concept of the Monroe Doctrine concept, where the brain and all the brain matter, including the substance of the brain and the fluids inside the brain, they all have a balance. So if there's anything that is altering this balance, it will obviously cause an acute brain dysfunction. So if you have a hematoma, if you're in an accident, or if you are hit, or if you fell, and there's a buildup of blood between the layers of the meninges, this will obviously increase the intracranial pressure. Aneurysms, inflammation of the substance of the brain, encephalitis, meningitis, hydrocephalus, both communicating and non-communicating hydrocephalus, as well as stroke and stroke syndromes. So as I said, all of this increase, essentially the physiology is an increase in intracranial pressure, which then manifests as an acute confusional state. As we go on, there are other miscellaneous causes. Your patient, most of the time, they may come, and on your initial history and when you take vital signs, you're able to tell something is off. They're hypoxic. Their blood pressure is low or is high. Okay, or there are signs and symptoms of sepsis and the septicemia spectrum. Maybe they have a fever, they are acutely confused, peripheries are cold, they're not making urine, and essentially you are able to identify a cause of infection. So your initial vital signs are normally very important. Your patient could be acutely confused because they do not have enough oxygen reaching their brain. They're hypoxic. Okay. They could be acutely confused because they have poor cerebral perfusion as a result of hypotension. Okay. It doesn't matter whether the hypertension is because of sepsis or as a result of whether they are bleeding, the tap is open, so they're losing volume. Okay. They may come in hypertensive encephalopathy, acutely confused. You take the blood pressure, your systolic blood pressure is above 200, okay? Or they are septic. And this could be, this should be able to point you out that there is something going on physiologically that might contribute to the state in which they've come in. Essentially, when you have these acutely confused patients, you have a lot to think about. Your differentials are numerous. Okay, you have to actually think systematically, system by system. The main things that you normally want to rule out are CNS things, infections, metabolic causes, because more often than not, one of these is deranged. Okay, one of these is normally deranged. But sometimes you might find that all of these are normal and you have to think outside the box. So you have to think, could there be anything that this patient is taking or was taken or was given that might contribute to the way they're presenting to you? Are they taking any prescription or non-prescription over-the-counter drugs, okay, including opioids and other psychotropic substances, antibiotics such as the class of fluoroquinolones? They might contribute to confusion. If your patient is taking alcohol, it could also be they're just intoxicated. They're acutely confused because they have had a lot of alcohol. Maybe they were out, they were binge drinking, and that could be the only cause of the confusional state. Or these patients could also be, it could be that they've been using these substances for a while, they are dependent on them, or their bodies are used to them, and they are now trying to stop taking the substances either by choice or being forced, and they are in withdrawal. For example, alcohol withdrawal will present with a spectrum of delirium. It's called delirium tremens, all the way. You can get an encephalopathy, one Nichols encephalopathy. Okay, so these are some of the things you have to think about. Okay, there is a notion that sometime when your patient is young, they are teenagers, late, early 20s, early 30s, whatever have you, and they come acutely confused, there's a tendency to sort of class them as intoxicated. Maybe they're using some drugs. Let's not forget that anybody who's an adult or even children can be able to use these substances. Okay, some of them might be able to buy. It's illegal, but some of them might be able to buy So don't classify your patients. You should not get an elderly patient in their 70s and their 80s, and you think because they are old, they're not taking alcohol or they are not using um, illicit substances or prescription substances, or they are withdrawing from this. So if your course is not organic, if it's not something within them, you also have to think about things that are exogenous, okay? Both prescribed and over the counter and illicit substances and such. So what do you do for these patients when they come to you? After taking a quick history, or being given a history by whoever has brought them in, their next of kin, their friends, relatives, colleagues. They told you this patient was confused, maybe they were at work, maybe they're at home, and they've now been brought to your ED. You've taken a history. From the history, you're not able to pick up much or anything that is definitive or straightforward. So what do you do? How do you investigate this patient? Anyone in the chat? Let's assume you've seen the patient, you've taken a history, you have vital signs have been taken. They're not hypoxic, they're not hypotensive or hypertensive. All your vital signs essentially look normal. They look okay. They're within their acceptable reference ranges. So how do you start managing this patient? Okay, someone is saying ABCs, good approach. I like that approach. Okay, but we've confirmed airway, breathing, circulation, everything is fine. There is no problem with the airway. They're breathing okay. Sometimes they're confused, but they are talking to you, so you know that the airway and breathing are fine, and they are not in any obvious rest distress. Your blood pressure and your heart rate are within the normal acceptable ranges. Okay. You've done a quick clinical examination and you're not getting anything. Your exam is essentially unremarkable other than the confusion. Okay, there's a lot of shout here for blood gas, RBS, baseline tests. I never know what baseline tests mean. Exposure, that's a good one. Okay. So, point of care testing, POCT, these are things that you should be able to do at the bedside. Okay. A quick blood sugar test, or RBS as it's normally known, it's something that can be done at the bedside and it can give you a clearer picture of how the patient's metabolic status is. Remember, hypoglycemia could actually be the only cause of your acute confusion. So when you have an acute confusional state, it could be as simple as low blood sugar hypoglycemia, or it could be as complex as a stroke and stroke syndromes and everything in between. Okay, so start slowly, start step by step. So point of care testing. So start with the blood sugar. Okay, if you're able to. If you're able to get a bedside blood gas analysis, if you're in a facility where you're able to get this is normally the best. It can give you a quick, you're able to glance at it and get a quick look of the patient's, the important electrolytes, the sodium, potassium, calcium, and chloride. You're able to check the metabolic status of this patient. Are they in acidosis? Are they alkalotic? Okay. And then after you've done sugar, assume sugar is fine. What next? Somebody was saying baseline tests. What are these baseline tests and what are you looking for when you're doing these tests? Okay. Electrolytes. I would recommend the full electrolyte panel, the so-called extended electrolytes. In our setting, it normally comes as UEC's kidney function test, urea electrolytes, uh, and now you can include calcium, you can include magnesium, you can include phosphorus or phosphate. Okay. If you're able to, you can include a thyroid profile. Full blood count. What are you, if you are doing a full blood count, I'm not saying it's bad to do. I mean, you can always do it, but what in the full blood count are you checking? What is of importance in the full blood count in a patient who's acutely confused? So full blood count, you're looking at the differentials, white cell count, red cell count, HB. So you're assuming white cell count is high. Uh, what if your patient has a leukemia? Their white cell count is 200. What if your patient has a leukemia? Will the white cell count really help you? Will the HB level or the platelet level help you? Your patient has a leukemia, they're on treatment. Their baseline white cell count is 150. Does it really help you much? I know here the thinking is that elevated white cell counts more often than not means that there is an infection. That's not true. If you have a patient, for example, who's been in an accident, okay, they're bleeding. If you have a patient, for example, who was like right now, for example, we have there's a cholera outbreak. So you have a patient who's coming and they're hypotensive. They've been having gastrointestinal symptoms, diarrhea, vomiting. They're obviously dehydrated. When you do a full blood count, everything will be high. You'll have a high WBC, high HB, high RBS, because your blood is made of two components. There's the fluid component and there's a cell component. So it's a ratio. So imagine if there's water and sand in a glass. If you reduce the water, it looks like the sand is a lot. So for a patient, for example, who has cholera and you do a CBC and you see everything is high, does it mean it's because of the infection? Maybe they got cholera a few hours ago. So they are losing a lot of fluid, which makes their cells look more than usual. So you rehydrate them, you don't give them any antibiotic, and then you repeat the full blood count after, let's say, 6 to 12 hours, and everything looks normal. It doesn't help you much. CBC doesn't help you much. It shouldn't be the point of your diagnosis. It shouldn't be the center point of your diagnosis. You should not be able to do a CBC and then you're seeing neutrophilic leukocytosis, and automatically you load this patient up with antibiotic. It's an adjunct, yes, I agree. It can be able to give you an idea of what could be going on, but it should not be the main thing. Remember, infections are a clinical diagnosis. You do not need a full blood count to find out whether a patient has an infection. Okay? There's nothing like a blood infection. That infection in the blood is coming from somewhere. There is a source because our blood is not exposed. We have the skin barrier which covers everything. So there has to be a source of infection. Do they have a flu? Do they have a UTI? So there has to be a source. Okay. So yes, you can do a CBC, full blood count, but it should not be the center point of your investigations. For these acutely confused patients, their endocrine metabolic panel are more important. Electrolytes are more important. Metabolic status is more important than a full blood count. But you can have a full blood count as an adjunct investigation. Somebody is saying CRP, procalcitonin, and all those inflammatory markers, they have zero value in the emergency setting simply because you cannot make a decision based on CRP, ESR, and all those things. Okay, they are good for inpatient management where they're able to trend the daily increase or decrease of the CRP, and they're able to know whether your patient is getting better or worse if they did have an infection. But in the ED, doing a CRP for the sake of it, it doesn't help you much. Doing an ESR, it doesn't help you much. For example, if you're male and you're female, you will always, and you're normal, you are physiologically okay, you will not have the same ESR levels. And there's even a different reference range for males and females in ESR. Okay, so endometabolic panel is important, extended electrolytes is important. You also have started thinking about exogenous causes. So if you're able to, a toxicology screen is important, but then acutely it doesn't help you much. Okay, most of the time when you have a toxicology screen, it's normally a urine test. It takes quite a lot of time to get the results. Some of them actually have to go to the government pathologists. Okay, so we've talked about point of care testing. We've talked about labs. ECG, yes, ECG can always help. Okay, if your patient has God forbid, a coronary syndrome and they are not perfusing, so they are hypoxic or they are hypotensive, and the cause of that hypoxia or hypotension could be the heart. So ECG, I agree, as a point of care testing will be helpful. What about imaging? What's your go-to imaging? Brain imaging, if I were to be specific, what would you go for that is available? Available, quick, and you can get a report or you can be able to look at it and make a decision. A brain CT, a non-contrast brain CT is your go-to imaging of choice for the brain. So we're doing things to rule out metabolic causes. We're also looking at the brain to make sure whatever is causing this confusion is not something that is intracranial. And a non-contrast head CT, I think, is the most available, easy to do, and you're able to get quick interpretation either by yourself or by a radiologist and you're able to make or act upon it. So if you do a quick brain CT and you find the patient has an acute subdural hematoma, and you're able to call in the relevant specialty to continue the care of the patient. Okay. Any other that you can think of? Somebody is saying brain MRI. I mean, it's nice, but most facilities do not have a brain MRI. And even if you do, it's a long imaging technique. You typically need to be in the machine for at least 20 to 25 minutes. Okay, we had forgotten urinalysis, which is very important. Remember, I had mentioned the UTI, pyelonephritis spectrum, especially in the elderly, confused elderly patient. You have to make sure you've done a urinalysis. You have to. UTIs can acutely present as confusion in the elderly or geriatric population. So that's very important as well to complete your laboratory investigation panel. Point of care ultrasound. Somebody has pointed out point of care ultrasound. Yeah, I agree to some extent. You can use point of care ultrasound, but what are you looking for? Where would you do focus on? Is it the lung? Is it the heart? Is it the abdomen? So your history should be able to guide you whether you need to do point of care ultrasound. If you think your patient has uh, sepsis, okay, and you want to find out how much fluid or whether if your patient is in shock, sorry, and you want to find out whether a hypovolemic shock, it's a distributive shock, whether they need fluids, whether they've had enough fluids, so you can look at your inferior vena cava and it can be able to tell you whether this patient has enough fluid or whether you need to continue giving fluid if they're hypotensive, okay? And while you're looking at the IVC, you can always look at the abdominal aorta. I mean, they're next to each other. So if your patient is hypotensive and you're not able to figure out what is the cause of hypotension, it's always a good idea to make sure it's nothing intra-abdominal, an abdominal aortic aneurysm. Okay. If you think they have an infection, you can go ahead and investigate that infection. We are in the tropics, so malaria, dengue fever, all those things, they're endemic here. If you think you have patient has a community-acquired pneumonia, chest X-ray to confirm your diagnosis, not to make your diagnosis, to confirm whether it is true, whether they have a community-acquired pneumonia. Okay. Do you start them on medication? Do you give them fluids? Is it necessary? Is it important? If your patient is not hypotensive, they don't require fluid, do you just say, I have to give them fluids? If the cause of the confusion, or if you think your patient does not have an infection, do you just say, I mean, let me just give 1 gram of ceftriaxone just for the sake of it? I know a lot of people do this. You go to hospital, They do a number of lab tests. And even before you get results, somebody has already given you a gram or 2 grams of ceftriaxone. Sometimes some people have given you meningitic doses of ceftriaxone, and they have absolutely no reason or no indication for antibiotics. So this I would defer to your clinical judgment based on the history, vital signs, point of care testing if you have a blood gas. So if you need to give fluids, give fluids. If you need to administer medications, administer uh, medications as required. Everything has to have a reason. And if you're giving fluid, how much fluids are you giving? How will you know whether the patient has had enough fluids or whether they even need fluids? Okay, you have to have a way of monitoring and evaluating whatever intervention that you're doing. So what if you find nothing? You've done all your investigations, blood, urine, all the serological markers you can think about. You've sent a full toxicology panel. You've even done an MRI of the brain with contrast. And you even asked for an MRA, MRV, and it has been done, and it has been reported as normal. All the blood tests you've done, everything is normal within the acceptable normal ranges. So what do you do next? Do you just tell the next of kin or the friend of your patient, hatujapata kitu, we've not found anything, I think you should just go home? And you can clearly see your patient, the patient is acutely confused. What do you do next? Do you send them home? Do you call for help? What do you do? Everything that you could do at the bedside in the ED has been done and they are normal. All the tests, all the lab investigations, all the imaging investigations have been done and they're okay. You've taken a proper history, you've taken another history. Remember, emergency medicine is about triage and retriaging. So you took a first history, you did the investigations, they've come back normal. Another relative has come with additional history. They brought the medications that the person uses at home. You've looked at all the medications. There's nothing that would explain the acute confusional state. So what's your next step? And this is very important. As emergency practitioners, you need to have a clear disposition plan for your patient because you cannot keep them in the ED. Somebody else needs that ED bed. Okay, there's a lot of talk about somebody saying malingering, psychiatry, psychosis, rule out hysteria. How do you rule out hysteria? Good. There's a very, uh, somebody has mentioned to do an MSC, mental state examination. If you had not already done one, if you're not thought about it, this is now the time to do a mental state exam. This is not something to cram. Every time you are doing a mental state exam, it's always a good idea, go online, get a template, and then you can check off it. There are online resources that have these MSCs as a checkbox. You can get one and you can use it simply because you are not able to keep all the information that is in the MSC chart. You can't remember everything. Okay, you can remember some, but not everything. So it's always a good idea to have a point of reference. So an MSC will tell you whether you need to uh, call for help, call for other specialty if you have a psychiatrist, Psychologist, do you need to do any additional tests? Is there anything else anybody thinks they need to do that you've not done already? Any pointers, anybody? EEG? I'll just say if you find yourself that you're doing an EEG in the emergency department, that patient has been there longer than they need to be. VDRL, PITC, yeah. If you're not done these serological markers that I had mentioned, syphilis, PITC, STI, panel spectrum, you've not done any of them, this is now the time to start thinking about it. SIWA for alcohol withdrawal. Patient has never tested alcohol. Well, that's what they say, or that's what their next of kin says. Lumbar puncture. Would you routinely do lumbar puncture in the ED as an emergency practitioner? And how does it benefit you? I mean, if you're doing a lumbar puncture, the assumption is you've already made sure the patient does not have raised intracranial pressure in some form or another. You've already done either a fundoscopy, or if you're lucky enough, you've already done a CT scan and there are no signs of raised intracranial pressure. So if you do a lumbar puncture and then your CSF analysis, will you wait for those things to come out? So lumbar puncture, well, yes, it might have some benefit, but this patient will probably benefit with you now calling in the relevant teams, whether it's neurology, whether it's psychiatry. My recommendation is neurology. Psychiatry should be last, at the very end of your list, once you've ruled out any and all organic causes and exogenous causes of an acute confusional state. And there is nothing that can explain the way your patient is organically or exogenously. Okay. But remember, like I said, acute confusional state, if not managed properly, can lead to longer hospital stays, poorer treatment outcomes, worsening morbidity and mortality. So as emergency clinicians, our role when you have these patients in the ED is to rule out any organic cause and to make sure there is no exogenous cause of the acute confusion. To rule out things that are within the patient, any derangement that affects the patient's physiology, and to make sure there is nothing this patient is taking or being given that explains the state they're in. Once you have done that and there is nothing to go by, you've already done good by your patient. It's now time to call in additional resources, additional help. So inpatient teams, neurology, psychiatry, whatever is available to you, get your patient admitted. Okay? You cannot discharge an acutely confused patient whom you've not figured out the cause of their confusion. You cannot just tell the next of kin, Tumehakikisha hakuna kitu ako sawa, and clearly hayuko sawa. Okay, so they need to be admitted. The inpatient teams will take care of. Remember, we are not inpatient teams, we are ED. Our job is to make sure, number one, patient does not die. Number two, you prevent morbid outcomes, or you prevent catastrophic morbidities. Okay. Most of the time when you're doing all these things, you will come up with a diagnosis. You'll be able to get a diagnosis, and that helps you. But that's not the goal. That's not what you should aim for. As EM practitioners, our job is not to find out, is not to get diagnosis. Our job is to keep the patient alive, prevent them from dying, prevent them from getting adverse outcomes from whatever is ailing. In summary, acute confusional state is multifactorial. It can be as a result of so many things, as a result of so many physiological derangements, whether organic, whether the cause is exogenous. Okay. You will do your patient justice by making sure you've evaluated them properly, clinically, and you've done investigations that are relevant. POCT means point of care testing. These are things like ECG, RBS, if you have serum ketones, things that you can do at the bedside. That's what POCT means, point of care testing. One common cause of acute confusion is CAT, MIRA, cannabis edulis, and this related leaves. What is the antidote? Anybody knows? I don't know whether there's an antidote to MIRA. Is there really? I don't think there is. Most of these things you just need to stop, and then it stops its stimulating effects. So if there are no other questions, clarifications, thank you everyone for joining us this evening. I hope the presentation will be helpful in your clinical management of patients. When you get such kind of patients, think broadly. Don't zero in on something and focus on it. This is one of those things, if you don't take your time and evaluate your patients properly, you end up missing things that are very obvious. You do the big things, somebody comes in acutely confused, you go for a CT scan and you forget to do a blood sugar. By the time you're realizing their sugar is less than one, and now you're rushing to administer glucose and things like that. So systematic approach, history, clinical examination, point of care testing, relevant investigations, and imaging. Make sure there is no organic causes of the confusion. Make sure there is no exogenous causes of the confusion. And if they are still confused at the end of it, get them admitted, get the relevant inpatient teams to continue the care. I mean, physicians would be more than happy. I know internal medicine physicians, they like making diagnosis. For us emergency clinicians, our job is not to make diagnosis, is to keep the patient alive and prevent further harm. Okay.